interestingly, the perihilar and distal cholangiocarcinomas, meaning the cancers that arise from the duct outside the liver or at the entrance to the liver, tend to be diagnosed at an earlier stage, with around half of them being diagnosed at stage 1 or 2, because, as one might expect, when the duct gets a cancer, even small one, it causes biliary obstruction, which leads to jaundice early on. And so on the one hand, that's good, and that people might be diagnosed just with the cancer at a localized stage that's amenable to surgery. And so there is a greater chance of being a candidate for resection, or in occasional cases, transplant for perihilar tumors with certain criteria in place. But they're still high risk for recurrence. And so while it is good to have this biologic selection for an early signal of jaundice, getting an earlier diagnosis, there's still a cancer that tends to recur, has a higher risk of recurrence. Just to add another challenge, unique, I think, to biliary tract cancers, is the biologic heterogeneity of these different anatomic sites, and which makes it very difficult to identify what treatments are working or which treatments aren't. And what I mean by that is that while biliary tract cancers as a whole are rare, even within that relatively rare group, there are subsets defined by certain mutations in the intrahepatic location versus certain mutations or overexpression of proteins in the extrahepatic or gallbladder location that define very distinct genomic subgroups. So it's rare subgroups within a rare cancer. And it makes it very difficult on a high level to identify what are those key relevant tractable subgroups that would respond to a particular treatment if we only drew our lens to them and knew what we were looking at. So these rare subgroups is another challenge to making progress. We do know that there is a small subgroup of around between 1% and 3% of patients that have microsatellite instability across tumor types, whether it's biliary tract cancer or colon cancer or breast cancer. There's a subset of patients that have a phenomenon called microsatellite instability that leads to an accumulation of frame shift mutations throughout the tumor genome that lead to an exquisite sensitivity to immune checkpoint inhibitor therapy, probably because of neoantigens, meaning new protein constructs being created by these mutations that make the tumor more recognizable to our immune system. So in that subset of patients with cholangiocarcinoma who have microsatellite instability, we know that immune checkpoint inhibitors have a very high response rate depending on which study subset one looks at, 30%, 40%, 50%. A subset of those are complete responses, and the median durations of response tend to be in the 24-month range or longer. And anecdotally, we all have some patients. I have multiple patients now who have been cured, as far as we can tell, who have had complete responses and have not recurred. And so there is an exquisite sensitivity for that 1% to 3% group who have microsatellite instability. Beyond that, though, it's more of a shotgun effect. We aren't sure who responds to immune checkpoint inhibitors. And by themselves, immune checkpoint inhibitors as monotherapy have a pretty low response rate, around 5%, in biliary tract cancer patients without microsatellite instability. And who are those 5% of patients? We don't know. There isn't a dominant theme to identify them.